of Urology, part of the teaching staff of the High Institute of Infertility Diagnosis and Assisted Reproductive Technologies, head of the Teaching Center for Iraqi Board of Urology. Dr. Ala, the floor is yours.
السلام عليكم وشكرا جزيلا لكم ونشكر كلية طب النهرين على هذه الدعوة. We will tackle today the important subject of common renal and urological problems in pregnancy that ranges from simple UTI to repeated UTI to life-threatening urosepsis. The second more common problem is acute low pain associated with hydronephrosis, hydroureter, mostly caused by uteric stone or other pathologies. Today we have two distinguished speakers who will tackle this subject. The first one is Dr. Sahar Hassan Fartousi. She's a lecturer at the Department of Gynecology, Obstetric and Obstetrician. She's Iraqi board certified. The second speaker is Dr. Ahmed Abdelhadi Isa. He's a board certified urologist and he is an assistant professor of urology at Al Iraqiyya Medical College. He is a fellow of Albani Medical Center, which is a distinguished center in the United States. And we have Dr. Ali Mohsin. He's from Asino. He's a PhD for the medical and compliance manager of Asino in Iraq region. تتفضل الآن دكتورة سحر to start her presentation regarding the current UTI in pregnancy.
Thank you very much, Dr. Ala.
دكتورة سحر عفوا بس قبل لا تبدين محاضرتك اطلب من السادة والسيدات الحضور ان عندنا السكشن مال Q&A. اي سؤال يقدرون يسألوه رأسا واحنا في نهاية المحاضرات راح نجاوبه او اثناء الكلام ممكن نجاوبه. فالعدة سؤال يقدر Q&A اسفل الشاشة Q&A مكتوب Q&A يقدر يسأل السؤال واحنا نجاوبه او في نهاية المحاضرات نقدر نجاوبه. تفضلي دكتورة سحر عذرا على المقاطعة.
عفوا واضحة قدامكم السكرين؟
نعم واضحة دكتورة واضحة نعم.
Yes. My topic is one of the most important and challenging topic in the pregnancy, which includes the recurrent UTI in pregnancy. Our objective including definition, pathophysiology, incidence, classification, clinical approach, workup, and treatment. At the beginning, we must know about some notes about the definitions. According to the International Classification of Disease, ICD-10, the UTI or urinary tract infection are infection affecting structures participating in the secretion and elimination of urine, which including kidneys, ureters, urinary bladder, and urethra. Pregnancy is in pregnancy, this infection can lead to serious adverse maternal and neonatal outcome, so it is important to be known. And we must know the type of recurrent urinary tract infection, which is defined as more than one UTI before or during pregnancy. While in non-pregnant women, it means the infection, more than 3 infections in the previous 12 months or 2 episodes of UTI in the last 6 months. Also, we must know about what is the bacteriological persistence. Bacteriological persistence is a continued bacteriuria with the same organism 48 hours after the initiation of treatment. While a relapse is a recurrent urinary tract infection where the organism that was previously treated persists in the urinary tract 2 weeks after completion of the treatment. A reinfection, which is a true recurrence, is the urinary tract infection occurring after complete sterilization of the urine with the organism originating from outside of the urinary tract, either a new bacterial strain or strain previously isolated that have persisted in the colonizing flora of the gut vagina more than 2 weeks after treatment. Regarding asymptomatic bacteriuria is a true bacteriuria, which is more than 100,000 colony forming units per ml in the absence of specific symptoms of acute urinary tract infection. While symptomatic UTI, which including acute cystitis or pyelonephritis. In acute cystitis, the same significant bacteriuria, but associated with the bladder mucosal infection, which reflected by symptoms like dysuria, urgency, frequency, nocturia, hematuria, and suprapubic discomfort. Pyelonephritis is the identification of the same, at least 100,000 bacteria per ml of a single uropathogen in a midstream specimen of urine. This associated with inflammation and renal of the renal parenchyma, which reflect by a severe symptom, the presence of systemic illness like flank or renal angle pain, pyrexia, rigor, chills, and nausea and vomiting. All these definitions are agreed with the clinical guidelines of American Urology Association, which released in May 2019. Regarding the pathophysiology, why the pregnant woman is more affected or more faced UTI, the pathophysiology including the three arms, which is hormonal, mechanical, and hypertrophy of the kidney. Regarding the hormonal aspect, we all know that there is a stasis of urine during pregnancy, which predisposes to infection. This urine stasis, because of high progesterone level, which is an increase in pregnancy, lead to relaxation of unsmooth muscle of the whole tract, and this will lead to dilatation of the pelvis and ureter, and this precipitates a vesico-urethral reflux that may increase the ascending infection. Also, the mechanical arm of the risk factor or the precipitating factor of recurrent UTI in pregnancy is occurred by gravid uterus, because there is pressure on the bladder wall, which get pushed up into the abdomen by the gravid uterus, 50% in the primigravida, and for less extent in the multigravida. And this ascending will lead to ureteric pressure at the pelvic brim, which lead to obstruction, and this lead to hydronephrosis and hydroureter. Hydronephrosis and hydroureter may occur in both kidneys, but it is more in the right than the left. Also, the structural hypertrophy and functional hypertrophy of the kidney may precipitate the recurrence of urinary tract infection during pregnancy. The functional hypertrophy including increasing the renal blood flow, increasing the glomerular filtration rate by 40%, increase the renal plasma volume by 60%, and this led to decrease into blood urea and serum creatinine and glucose urea, and sometimes due to increased filtration by the kidney, this lead to increase the structural hypertrophy of the kidney. Also in female, we have a vaginal infection may cause or mimic UTI, which are common in women in reproductive years, which is the years of getting pregnancy. This affects 25 to 35% of women aged between 20 to 40 years, and the main method of discriminating between the two is depend upon the vaginal and urinary culture. Regarding the incidence of recurrent UTI during pregnancy, it is changed between the area in the world. It is 28.7% in white and Asian, 30% in blacks, and it is 41% in Hispanic. The prevalence increased with age, with low socioeconomic state, and with sexual activity, multiparity, and untreated pathological events like stones or crystals. The antenatal screening is recommended for all pregnants. A routine midstream specimen of urine during pregnancy for all women at the first visit booking, which is occur in the first trimester, and there may be indication for repeat the screening when we have a contaminated specimen, a history of recurrent infection outside of pregnancy, a known or unknown structural abnormality of the urinary tract. We may repeat the screening in second and third trimester. The most common organism that may affect the urinary system, including gram-negative perianal area bacteria, most commonly the Escherichia coli, which represents 77% of the microorganisms that affect the urinary system during pregnancy. In the other extent, Klebsiella, Proteus, and for less extent, Pseudomonas and the Staphylococcus aureus and other Enterobacter. All these bacteria can be gathered by the word keeps, in which K refer to Klebsiella, E for E. coli, and the other key for Enterococcus or Enterobacter, the P for Proteus and Pseudomonas, and S for staph infection. This diagram represents the total microbial species isolated from the urine sample, in which the blue column represents the female aspect of infection. Also, we see that the E. coli have the major contribution of UTI during pregnancy, followed by Klebsiella, Pseudomonas, and Staphylococcus, and for lesser extent, Candida and Proteus. Regarding the risk factor for the asymptomatic bacteriuria in pregnancy, the low socioeconomic state, sickle cell trait, diabetes mellitus, neurogenic bladder retention, history of previous urinary tract infection, and structural abnormalities of urinary tract. Also, the presence of renal stone may contribute as a risk factor for recurrent UTI in pregnancy. Asymptomatic bacteriuria may have many complications if not treated, ranging between severe cystitis, pyelonephritis, and preterm labor, anemia, and preeclampsia, and many prenatal and postnatal morbidity and mortality. Regarding acute cystitis, in which the incidence is 1 to 2%, in addition to midstream urine, a clinical diagnosis is based on symptoms. يعني asymptomatic bacteriuria, there is no symptoms, but there is bacteria in the urine. While in acute cystitis, there is, in addition to the midstream urine diagnosis or clinical diagnosis, there is a symptom associated with this, like dysuria, urinary frequency, lower abdominal pain, suprapubic pain without fever, and there is biuria may also be present. The management divided into symptomatic measurement and antibiotic. The symptomatic, including hydration to wash the bacteria, encourage the pregnant women to intake plenty amount of water, and painkiller and antispasmodic as a tocolytic. While the antibiotic, we should regard the teratogenicity and choose the type of antibiotic that not affect the pregnancy, especially in the first trimester, the period of embryogenesis. Regarding pyelonephritis, also the incidence is 1 to 2%, and it is usually present as an acute episode. If the acute cystitis or asymptomatic bacteriuria left untreated or partially treated, there may be ascending infection that affect the ureter and ascend to the kidney, and may affect also the tissue of the kidney. And the clinical diagnosis of this category depend on full maternal clinical history and examination, symptoms including chills, rigors, flank or renal angle pain, nausea and vomiting, usually dehydration, and less commonly dysuria. The frequency and fetal tachycardia also may be present. The investigation including midstream urine, and in addition to midstream urine culture, assessment of fetal well-being, blood culture, aerobic and anaerobic, low and high vaginal swab, complete blood count, renal function test, including creatinine, urea, and electrolytes, and urine analysis for proteinuria and biuria, because there is high incidence of preeclampsia incidence if there is recurrent pyelonephritis during pregnancy. The effect of the pyelonephritis on the fetus, there is increased incidence, as we all mentioned, in the perinatal and morbidity and mortality. And there is also an increase in the incidence of miscarriage, increase the incidence of prematurity and intrauterine growth restriction. Regarding the management, pyelonephritis is more aggressive and the patient is in pain and this and fever and severe nausea and vomiting and dehydration. So at first we must admit the patient to hospital. Some patients can be managed as an outpatient. But if there is dehydration and severe fever, you must admit the patient to hospital. And we start with rehydration by intravenous fluid. And we must use an empirical antibiotic treatment, waiting for blood culture and urine culture. And then after subside of the fever, by 24 or 48 hours of subsiding of fever, we shift to oral antibiotic. Then after 2 weeks, we reculture to exclude persistent bacteriuria. This table represents the choice of antibiotic in asymptomatic bacteriuria. Recurrent urinary tract infection are common during pregnancy because of the pathophysiology we mentioned before, and require a prophylactic treatment. In a pregnant woman with urinary group beta streptococcus infection should be treated and should be received intrapartum prophylactic therapy. يعني احنا عندنا challenge انه يصير عندنا recurrent bacterial infection during pregnancy. We must treat the patient for at least 1 month. And also, if there is biculture, beta hemolytic streptococcus, it is important to mention that the beta hemolytic streptococcal pathogens affect the fetus, especially even after delivery. After delivery, when there is beta streptococcal infection, there is risk of meningitis in the baby, despite there is no effect of UTI during pregnancy. The recurrent UTIs during pregnancy may require antibiotic prophylaxis for at least 1 month. If the UTI thought to be related to sexual intercourse or postcoital or bedtime, a bedtime dose of nitrofurantoin 50 milligram may be appropriate, and it's lasting for 1 month. And we may give cephalexin 250 milligram also can be used. Regarding the safety of antibiotic choices for UTI, and we start with nitrofurantoin, which is the first choice in asymptomatic bacteriuria and in acute cystitis. It is considered to be safe, a category B during pregnancy, and it is used during pregnancy, but it's stop use, or it is not recommended to be used after 36-week gestation, because there is possibility of hemolytic anemia in the newborn due to immature erythrocyte enzyme system. The effectivity of a treatment of nitrofurantoin thought to be 86% in many studies, and it attained therapeutic concentration in the urine, and it is suitable for asymptomatic bacteriuria as well as acute cystitis. It is not appropriate for treating pyelonephritis because it does not achieve adequate tissue penetration. Regarding trimethoprim, the most important point I want to mention that the trimethoprim is antifolate, so we can use it in late trimester, but in early first trimester, it is teratogenic. Cephalosporins, although it is considered safe in pregnancy, category B, the use of broad-spectrum antibiotic should be avoided when a narrow-spectrum antibiotic would be more appropriate. Also, there are concerns that the broad-spectrum antibiotic increase the risk of Clostridium difficile and methicillin-resistant Staphylococcus aureus, اللي هو احنا نسميها MRSA, and resistant UTIs. Clostridia difficile infection can be life-threatening for pregnant women, and there are a case report of both maternal death and stillbirth infants. Regarding amoxicillin, although all penicillins are considered safe in use in pregnancy, however, there is evidence that the resistance to amoxicillin is higher than the resistance of trimethoprim. For this reason, amoxicillin is not suitable as an empiric therapy for acute cystitis, but it can use if the urine culture showed susceptibility for ampicillin. Regarding the recurrent urinary tract infection is challenging to treat it, and because the main treatment option is long-term antibiotic prophylaxis, and this long-term antibiotic prophylaxis poses a risk for emergence of bacterial resistance. Some options to avoid this risk are available, including the use of cranberry products. A cranberry is a term derived from contraction of a cranberry. This cranberry are composed of water, 88%, and the remnant is organic acid, including salicylate, fructose, vitamin C as high as 200 milligram per kg of fresh berry, and a flavonoid and the active substance, which is anthocyanidine, and other products. These products affect the villi of E. coli. E. coli مثل ما نعرف have a villi اللي هي ترتبط small filaments that enable the bacteria to adherent to the host tissue, which is the mucosa of a bladder, and the content of mannose in this cranberry will distract this villi and prevent the adherence. This hypothesis that cranberry work principally by preventing the adhesion of this microorganism اللي هو E. coli, decrease the risk of recurrence. لذلك مرات ننطي as يعني substitute of antibiotic for 1 month at least to prevent the reinfection or recurrent UTI. This multiple studies starting from 1994 to 2010, all these studies, many of these studies يعني give a significant benefit of using of cranberry as a substitute of long-term antibiotic for recurrent urinary tract infection. So at the end, the key recommendation of this lecture is screening for asymptomatic bacteriuria should be performed ideally at 12 to 16-week gestation for all women. Imaging of the renal tract may warranted where pyelonephritis reoccur and or it is a slow response to treatment. Do not prescribe trimethoprim for pregnant women with established folate deficiency and in the first trimester. Taking a single sample of urine culture before empiric treatment is started حتى نقلل الresistance. Women with symptomatic bacteriuria with systemic sign of infection should be admitted for intravenous antibiotic pending the result of a blood culture and urine culture. When choosing antimicrobial regime, it is important to consider issue of teratogenicity and absorption. In case where a clinical improvement failed to occur within 24 hours of starting a treatment, or where there are additional comorbidities, additional senior and medical and microbiological advice should be sought. Repeat urine culture should be sent a week after antimicrobial treatment to decrease the persistence and to ensure that there is no bacteriuria and the bacteriuria has been cleared. Nitrofurantoin can be used for prophylaxis, but should be avoided near term and when delivery is imminent because the risk of neonatal hemolysis. Thank you very much.
Thank you. شكرا جزيلا دكتورة سحر على المحاضرة. طبعا اكو الأسئلة وانا ايضا عندي أسئلة بس راح نعيفها للأخير. تفضل الآن الأستاذ المساعد دكتور أحمد بإلقاء محاضرته.
Thank you very much, Sino. Thank you very much, Dr. Alla. Thank you very much, Dr. Sa'af, for giving me a chance to speaking about the ureteric stone during pregnancy. Ureteric stone during pregnancy. I think it's one of the most common subjects affecting the pregnant women. Nephrolithiasis, commonly encountered. By going to the background, renal colic is the most common cause of non-obstetric abdominal pain, necessitate hospitalization. And about 25% of women had one or more procedures for kidney stone during hospitalization. Urinary stone during pregnancy, affecting 1 in 244 pregnant. And another study says that it's affecting 100 one in 200 to 2,000 pregnant women. It is more common in the Caucasian than African women. It was associated with higher rate of preterm labor and premature rupture of membrane by 7% to 29% comparing Caucasian to the African. Majority occur in the second or third trimester. Multiparous greater affected than primiparous by 3 to 1. Actually, the incidence of stone in general population, it is higher. It's affected about 10% in population. The incidence increasing over the last decades due to many factors. 40% increase in hospital visits and 50% increase in annual expenditure from 19 to 2000s. In general population incidence, this is due to obesity, environmental changes, increase in the diseases and comorbidities like diabetes mellitus and metabolic syndrome. And is this the same applicable for the pregnancy? Is the pregnancy carrying more risk than the general population? Actually, one study at tertiary centers from 1991 to 2011 followed up and reviewing the pregnant ladies with the stones and pregnant ladies with the stones show there is no difference. And the question is that why it is important to focus on the ureteric stone in a pregnancy, although the incidence doesn't differ from the general population. This is due to, I think Dr. Ola agree with me, this is due to the challenge in diagnosis and management of the ureteric stone during pregnancy. It is a challenging subject to treating a pregnant woman because we are dealing with two patients, the pregnant lady and the fetus. The challenge in imaging, the challenge in taking the decision when to interfere and what to give to the pregnant lady, which is more safe for her and for the fetus, making this subject is more challenging for the urologist. There are several anatomical and physiological changes affecting the pregnancy, making the stone more common and formed in the pregnant lady. I think Dr. Sahar speaking about many of these, like the hydronephrosis, which is the anatomical alteration. The hydronephrosis from grade 1 to grade 2, you can see the picture. This is what you see in the ultrasounds. And it is due to 90% of the right kidneys presented with hydronephrosis and 67% of the left kidney with the hydronephrosis. This is due to two things. The mechanical effect of the uterus and the ovarian venous plexus, which is compressing the right ureter, and the left ureter will be safe due to the gaseous filling the sigmoid colon, and the effect of the progesterone that causes relaxation of the muscles, decreasing peristalsis, and making the urine more stasis. The physiological alteration in the urinary pregnancy, the increase in GFR, an increase in glomerular filtration rate for the pregnancy due to increase in the cardiac output and decrease in renal vascular resistance. There will be more 50% clearance increase for the creatinine. And this means that 50% more increases in excretion of substance like calcium, sodium, and other stone-forming substance. The sodium, due to the high level of the natriureteric hormones, progesterone, HCG, aldosterone, more sodium. And Dr. Ola, I think, agree with me that with each sodium molecule excreting in the urinary tract, it will be replaced by calcium molecule. So we are speaking about hypercalciuria, which is one of the most common causes of ureteric and renal stones for the persons, whether it's pregnant or non-pregnant. By increasing sodium excretion in the urine for the pregnant lady, it means increasing in calcium excretion. This is number one. And number two, there will be gestational hypercalciuria, more filtered calcium load in the urine. And due to the effect of the placental hydroxylase enzyme, which causes increase in 125 hydroxyvitamin D3 production, increasing in the intestinal absorption of the calcium, negative feedback suppression of the parathyroid hormone, decreasing in the tubular reabsorption. So factors that causing more hypercalciuria for the pregnant lady more calcium filtered through the kidney, decrease in tubular reabsorption with each sodium molecule replacing by calcium. All these factors leading to more calcium stone formation in the pregnant lady. Although there is a glycosuria, the renal threshold for the glucose decrease and decrease in GFR. The type of the stones found in the pregnant lady is the calcium phosphate stone, different from the other type of stone, which is calcium oxalate for the general population. This is not all the story for the stones in the pregnancy. The increasing the GFR, it means more increase in substance decreasing the or prevent stone formation, like citrate, magnesium, glucosamine, and nephrocalcine, uromodulin, and thiosulfates. All these substances, actually there is look like a bottle between the stone crystals formation and the stone inhibitors. All together share like a bottle. The more the calcium, the more the sodium, it means the more stone, and the more the citrates, the more magnesium, more the stone inhibitors clearing the stones. In this balance, the pregnant lady goes in actually. The challenging subject in the ureteric stone is the imaging, starting by the simple, cheap, and safe, which is the ultrasound. Ultrasound reported to be sensitive and specific in detecting renal and ureteric calculi by 35 to 95%, especially in the lower end. And there is a techniques used by the radiologist to detect, to differentiate the physiological hydronephrosis from the obstructed or pathological hydronephrosis, which is the visualizing of the ureteric jet. As you see in this picture, you can use the probe of the ultrasound by changing the mode of the ultrasound to the color Doppler, assessing the jet of urine, asking the patient to be in a full bladder, putting the probe, waiting for 1 minute to 3 minutes, assessing the passage of the urine through the ureter in order to be sure that the ureter is not obstructed. The disadvantage of this is that 13% of the pregnant lady have normal absent of the ureteric jet. The transvaginal ultrasound for detection of distal ureteric calculi, and the measuring of the renal resistive index. Doppler-assisted measurements for the renal resistive index has been described to distinguish physiological from pathological. In pathological, there is increase in the renal resistive index suggestive of pathological obstruction. If the ultrasound is not functioning well, you can use the IVU. I know the ionizing radiation is a matter of challenge and is teratogenic for the fetus, maybe even for the siblings. But low dose of the radiation can use if you are not sure about that. There is two types of IVP models, that the 3 shoots IVP and single shoot IVP. The 3 shoots is that Scott fill, the KUB, then 30-second, then 20-minute films, and the single shoot is the single film 5 minutes after the IV contrast injection. The things that against that is, you know, the teratogenicity of the X-ray and the superimposition of this fetal skeleton that can obscure the visualization of the calculi. The second lie is the MRI. MRI can be used, as the American Radiologist Association says, you can use MRI at any type or any time in the trimester. They are using the half Fourier single turbospine echo HESTI, which is a special protocol using the magnetic resonance imaging for urography. They can use it in special instances for the pregnant, which is a rapid one, and for the young adults or young patient not in sedation. That is using T2 actually. The MRI showing the stone as a filling defect, not the stone itself. It shows the stone as filling defect in the ureter with dilated of the pelvic calcial system. The modality of choice for diagnosis of ureteric stone, renal stone is the CT scan. But again, the effect of the radiation on the fetus is the challenging things here. But the using of the low dose, ultra low dose CT scan can equal to 3 shoots IVP and even more safe. It has 95 and 98 specificity and sensitivity for detection of the ureteric and renal stones. This algorithm can show how you deal with the clinical suspected nephro or urolithiasis during pregnancy. You can do renal ultrasound, Doppler study for the renal sensitivity index, transvaginal for detecting lower ureteric stone. If it's positive, you can start treatment. If it's negative, you can give conservative management, continue the symptoms without with the management. You can do MRI. If it's positive, again, you can go through the management algorithm. Or if it's negative, you can do low dose CT. And if all these measures cannot specify the cause of the symptoms, you can use what we call checking ureteroscopy to see what's going on in the ureter. The pregnancy outcome really affected by the nephrolithiasis by many things, like the preterm labor and premature rupture of membrane with other pregnant complications such as preeclampsia and other complications. Most patients, the nice thing is that most patients can go conservative because the spontaneous passage of the stone less than 1 centimeter is more, and the effect of the progesterone on the ureter, making the ureter more dilated, give the pregnant lady a chance to expel the stone more, and they use the advancement and in the what we call it medical expersive therapy like alpha blocker like tamsulosin, which cause dilatation of the lower ureter, which is recommended by the FDA as category B for pregnancy, and use of narcotics. If all these measures failed to control the pain, what we call it colicky, refractory pain to drugs, or there is a sepsis infection, or there is obstruction in single kidney, or there is a renal dysfunction, preterm labor, psychosocial reasons, you will go for the more definitive management, not conservative, either by stent or percutaneous nephrostomy to decompress the kidney and relieve the hydronephrosis, or going for ureteroscopy for definitive management. And using ureteroscopy for definitive management, actually, it's the treatment of choice with the advancements of technology and laser. And the only things is that, I think Dr. Ola agree with me, the only things against the using of ureteroscopy is the using of fluoroscopy to assess the guide wire reaching the kidney. And you can replace that by using ultrasound to be sure the guide wire reaching the kidney. And with the ureteroscopy and laser lithotripsy, you can definitive treat the stone safely in the pregnant lady. And this is the algorithm, another algorithm for the patient management with suspected ureteric calculi when the patient presented with the flank pain, nausea, vomiting, unexplained fever, recurrent UTI, hematuria, and lower urinary tract symptoms like frequency, urgency. Initiate the workup by urine analysis, urine culture, as Dr. Sahar mentioned before me, CBC, renal function, serum electrolyte, ultrasound to see, abdominal pelvic ultrasound to see what's going on. If it's yes, the patient requires immediate intervention for the hospital. If it's no, you can still doing more ultrasound, serial ultrasound to see what's going on. If the ultrasound is still negative, you can do MRI or low dose CT. When you be sure there is a stone in the urinary tract for the female, you can start the painkiller, antibiotic, medical explosive therapy, and see if it's responding. It's okay. If not responding, for the stent PCN or definitive ureteroscopy with lithotripsy. So summarizing the things, despite the management, pregnancy conductive stone formation incidence is not increased. Ultrasound will be the first line, and low dose CT and MRI will be reasonable alternatives. Most pregnant women responding to conservative management, and stent PCN, it is a temporary management. Ureteroscopy can be performed in pregnancy safely. Thank you so much.
شكرا جزيلا دكتور أحمد. Thank you for your comprehensive lecture. Now to the open. Can we depend on general urinary exam in primary health centers for the diagnosis of UTI, as there is no culture and sensitivity?
Yes,
And just you find pus cells and you consider it as UTI.
Yes.
No.
Yes, I mentioned it before, the same question, I think. If there is biuria, we give a treatment, even if there is no symptoms. But if there is no biuria, the first visit, the recommendation is to encourage the patient to have a plenty amount of water to decrease the ascending infection, and we must counsel the patient about the stasis and about the physiological change in the renal system during early pregnancy in order to decrease the ascending infection. When the patient visits us, we send her for general urinary examination, and if the general urinary examination reveals any infection, we treat it. If there is no biuria, only bacteria seen, we recommend to send the patient for culture sensitivity before any treatment to be given if there is asymptomatic. But if there is cystitis and sign of suprapubic pain and biuria, we must treat the patient even if the general urinary examination only, without need for culture.
Okay, thank you. Another question from anonymous attendee. Dr. Ahmed, can calcium supplements in pregnancy cause ureteric renal stones in a dose of 500 milligram per day? No.
Actually, the calcium itself, like we mentioned before that the placental hydroxylase enzyme that increase the 125 hydroxylase vitamin D3 increase intestinal absorption. With increasing intestinal absorption, increasing the serum calcium, and this will lead decreasing the calcium filtered through the kidney. But I think the genetic susceptibility for the patient and the other things affecting more the pregnant lady, because there is a balance mechanism with the stone inhibitors like citrate, magnesium, and the other substances that prevent calcium crystallization. If this inhibits with low fluid intake, like dehydration, so we're speaking about supersaturation of the calcium, less crystallization inhibitors assure the calcium intake will affect the pregnant lady. But if the pregnant lady taking a lot of plenty fluids, good hydration, with the supporting herself with the like citrate supplements, I think the calcium will affect less on the urinary tract.
والعفو، تكملة لكلامك دكتور أحمد، شكرا طبعا، شكرا جزيلا. هو عادة بصورة عام pregnant or not, natural calcium بالحليب مثلا usually does not increase the risk of stone. A supplement, calcium supplement, especially in susceptible people or people who already has stones, they increase this. Yes, they do increase. بدل نقل المريضة مثلا إذا هي حامل نقول لها يا بشربي حليب أفضل أو تاكلين جبن هواية أفضل مما تاخذين كالسيوم، خصوصا على مثل ما تفضلت حضرتك عندها family history of stone disease and so on. السؤال التالي من قبل الدكتورة رشا: What is the role of laser therapy in calculating pregnancy, دكتور أحمد?
I think, Dr. Allah, you agree with me when we are speaking about definitive treatment for the ureteric stones. We are looking for a technology that is more effective, less affecting the ureter, more affecting the stone, and less affecting the patient. With the advancement of the laser technology, destruction of the stone or even dusting of the stone through the ureter represent definitive treatment for the ureteric stone pregnancy. While the other modality like pneumatic may cause retropulsion of the stone to the kidney, and this will make the problem continuous for the patient. For this, the laser play a major role in the treatment of the ureteric stone for pregnancy.
We have another question from Dr. Haifa Al Habib. What about the use of Uroclear during pregnancy? Uroclear مو أعتقد في شيء يعني.
Magnesium, I think magnesium magnesium citrate with potassium citrate. I think using this substance, like encouraging stone crystallization inhibitors, I think it's good in a pregnancy. But the recommended things that no one have any question about it is that increasing the amount of the fluid is more important than using the other substance. This is recommended by all the guidelines, whether it's European or the American guidelines. And the using of the magnesium and potassium citrate also, sure, there is a role for this substance in decreasing stone formation. Thank you.
شكرا. سؤال from دكتورة بلسم قحطان. She asked about IVF and renal colic and relation affect the IVF program. مع دكتورة سحر أو حضرتك تجاوبوا.
Well, I think the suitable person to answer this question is you, Dr. Ola. You are the specialist in the IVF center, and I think the mic for you. You can answer it.
Yes, دكتور.
هو العفو يعني هو الاي في اف هو كاي في اف كبروجرام هرمونال مانيبيوليشن وانجكشن بعدين اوفر بيك اب بعدين يعني فرتلايزيشن بالمختبر بعدين نرجع الامبريو للام كدايركت ريليشن هو ماكو يعني هو هذا ما له علاقه بهذا بس ممكن يسوي خلينا نقول early abortion مثلا مريضه اذا هي unlucky she just did IVF and she has severe pain راح يصير early abortion كحاله حالي natural pregnancy مثلا ولا هو يعني التاثير على ovarian hyperstimulation او غيرها او الاوفر بيك اب هو اعتقد ما له علاقه ما اعتقد تتفقين وياي دكتوره سحر اذا early pregnancy وصارت يوتريك كوليك تصير abortion مو صحيح ممكن؟
Yes.
نعم. دكتور احمد نزار ذنون عنده تعليق اكثر مما هو سؤال يقول Good evening to all colleagues. Double J or JJ stent in pregnancy in his practice in a few patients and with spontaneous abortion in early trimesters. And there are there any سؤال يعني are there any disadvantage in PCN rather than JJ stent in the management regime of fertility stone in pregnancy? This is a question to you, Dr. Ahmed. نعم.
I think, Dr. Ola, I think you agree with me that the most important things in the ureteric stone is the pain and the hydronephrosis for the pregnant.
Yes.
This is the cornerstone that stimulates the preterm labor and premature rupture of the membrane and the other complication for the pregnant lady.
Yeah.
And even in the non-pregnant lady, it is the indication for the definitive or stent placement for the patient, the pain and the hydronephrosis. Putting the guidelines are recommended to be as much as less invasive for the pregnant lady. When you have the chance to go conservative, you are going conservative.
No.
When the conservative tools fail to manage the ureteric stone, you forced to insert a double J or the percutaneous nephrostomy.
Yes.
Not only the pain present, the anesthesia itself carry a risk to a preterm labor and abortion for the pregnant lady. All these factors, I think, collecting together, affecting the pregnant lady, not the JJ stent itself.
Yes.
As this is my opinion.
مو بس هاي دكتور احمد يعني عندنا الجي جي تعرف الجي جي نسوي بلادر اريتيشن فظل يعني هي pregnant lady تروح وتجي للتواليت she might يعني squeeze or strain and then she might have this abortion يعني possibility. Another question اعتقد هذا الدكتور علي يقول دكتورة بلسم she asked about the safety of nitrofurantoin in the period of embryogenesis قصدها first trimester. نعم دكتور علي. حاطه ميوت العفو دكتور علي انت ميوت هسه حاليا.
Okay, thank you very much دكتور علا. Actually embryogenesis مثل ما تفضلت هي the early period of pregnancy اللي خلالها يكون الorganogenesis والvery early development of the embryo. وهنا طبعا اكيد احنا نخاف ليكون اذا اكو فد اي risk of congenital anomaly فراح تصير خلال هاي الفتره واللي هي first trimester. However من الليترشر ومن الستديز ما نقول ستديز وانما بوست ماركتنج ريبورتس اللي صارت على النيتروفيورانتون واللي شملت يعني اعداد مهوله اكشوالي من الخمسينات لحد اليوم لقوا أنه there is no incidence of congenital anomaly associated with the use of nitrofurantoin during the first trimester of a pregnancy. وهذا الكلام طبعا يمكن أنا أتصور ذكرته بواحد من السلايدات بالبرزنتيشن quoted from the textbook اللي هو drugs in pregnancy and lactation. So through the whole pregnancy nitrofurantoin can be given except for the last not last trimester وإنما last 2 to 4 weeks before labor due to the potential risk of neonatal hemolytic anemia.
اوكي شكرا جزيلا.
Thank you. شكرا.
عندنا سؤال من دكتورة إيناس الخزعلي. She asked about the Dr. Ahmed, the analgesia of choice that can be prescribed safely for a pregnant woman with renal colic.
The analgesia of safe, you can use the paracetamol with narcotic like tramadol. Try to avoid non-steroidal as much as possible.
No.
Although non-steroidal in a pregnant woman considered to be a cornerstone in the management of the aortic stone, because it's not only decreasing the pain, decreasing the intrapelvic pressure, enhancing peristalsis, but the risk of the premature closure of the openings in the heart. I think for this reason you have to avoid the non-steroidal as much as you can, and using narcotic with the paracetamol I think is safe for the pregnancy.
شكرا جزيلا. دكتورة رفل حسن تسأل سؤال هو يعني الأسينو حقيقة، وأنه سألت نيابة عنه. كنا can you send me this informative meeting through email. فأنا أسأل نيابة عنها وعن جميع يعني الموجودين.
نعم
إنه يا ريت تدزون ويا السيرتيفيكيت فد لينك لل
هو بالفعل أستاذ مثل ما حضرتك تقدر تلاحظ لي فوق على اليسرى بالشاشة الويبينار is recorded. فإن شاء الله الشباب راح يعني ورا ما نكمل إن شاء الله اللينك تكون جاهزة، وإن شاء الله تندز لي الإيميلات مال البارتيسيبنتس اللي سووا بها ريجستريشن إن شاء الله.
عاشت إيدك، شكرا جزيلا.
سؤال
من الدكتور أحمد نزار يقول question to Asino team. How long we have to wait Uvamine syrup innovation. يعني تصور قصة دكتور أحمد نزار ده ينتظركم لعد.
والله حقا أنا هذا السؤال صار سنين أسمعه من الأطباء. حقيقة يعني إحنا مبلغين الشركة أنه we are desperately needing this innovative formulation. أنه suspension or syrup for nitrofurantoin أو Uvamine for the pediatric age group especially. هو يعني حتى أن كشركة it is a very big market و very good potential، ومنتظرين إحنا حالنا حال الأطباء حقيقة. بس يعني I cannot promise أنه خلال سنة أو سنتين.
نعم. دكتورة نضال سالم as far we know that Uvamine cannot given during the third trimester to avoid gray baby syndrome and safely giving in first and second trimester. Is this is true؟ أتصور جاوبته سبقا.
أنا جاوبته already. لا هو الريستريكشن فقط خلال the last 2 to 4 weeks before labor.
نعم. From anonymous attendee, hello, can giving vitamin D3 to person with normal level of vitamin D increase risk of renal stone? Dr. Ahmed.
I think I are speaking now outside the pregnant ladies. The vitamin D increasing the absorption of the calcium, and still the risk of serum calcium, and one of the risks for hypercalciuria. Using vitamins, a normal person doesn't need vitamin D. Increasing the level of the calcium exposes the patient to a risk of hypercalciuria. I think we should avoid it if the vitamin D is normal.
نعم. سؤال أخير من دكتورة إيناس. Can trimethoprim be given with folinic acid during first trimester, especially when there is resistance to other form of antimicrobial؟ يعني مريضة عندها infection وسووا لها culture sensitivity طلعت sensitive فقط لليوفامين أو النيتروفيورانتون. Because as you know, the main problem of trimethoprim is the conversion of folic to folinic acid. فنعوضه بدالها folinic acid ويا يعني نعطي trimethoprim وياها folinic acid. يعني I'm not a pharmacist. I cannot answer this question. ما أعرف هذا دكتور علي can help us with this question.
والله دكتور أنا هم طبيب فما أعرف. Sorry.
Can I answer for some extent?
Yes, دكتورة سحر العفو. نعم.
So trimethoprim regarded as a category C. And as we all know, that category C is given if there is no choice for another drug. يعني إذا وصلنا إلى مرحلة إنه البيشنت تحتاج، وأنا ما أعتقد ممكن نوصل له في حالة UTI, there is many options other than trimethoprim during the first trimester we can give it. So it is يعني rarely إنه تطلع البيشنت resistant to Uvamine and resistant to cephalexin and types of penicillins, and we enforce to give trimethoprim in the first trimester. So better to be avoided, especially in the first trimester, because it is folic acid metabolism challenging. فيفضل إنه واحد يتجنبه better. بس إذا اضطرينا وكل أنواع الانتيبيوتكس is resistant راح نوصل إلى مرحلة إنه يعني it has to be given even if there is يعني risk on the baby.
شكرا جزيلا دكتورة سحر. سؤال from Anonymous again. Good evening everybody. Is Uvamine safe in lactation period?
نعم. Actually in lactation I have to make sure بس as I reviewed it يعني it depends. It is better to be يعني هو اكو trace amount may be secreted in the breast milk. So هنا مجرد نسوي risk benefit assessment. However إذا الطفل هو G6PD deficiency ف definitely it shouldn't be given.
Yes, thank you. سؤال الأخير من دكتورة أميمة. دكتور أحمد يقول what about the hydronephrosis during pregnancy based treatment؟ يعني any hydronephrosis during pregnancy دكتور أحمد.
I think this is depend on the degree of hydronephrosis. If we are not speaking about physiological or pathological point of view, we are speaking about the degree of hydronephrosis. If it's severe hydronephrosis with severe pain, and there is no obvious cause for this hydronephrosis, I think double J maybe represent sure if the conservative treatment failed to control this hydronephrosis. I think double J or JJ stent or PCN, it will be the temporary treatment for this hydronephrosis.
Yes, so it's cause directed other than يعني نقول hydronephrosis. The cause of hydronephrosis is most important. Yes. This is all what we have from the audience about the questions. I have a question about the cranberry. العفو دكتورة. نعم دكتورة سحر.
العفو. بس بالنسبة لليوفامين during lactation, I have been read some studies about إنه بالfirst month of يعني after birth in lactation هو better to be avoided, but يعني الstudies تقول إنه secretion in breastfeeding is low. لذلك ممكن واحد يستخدم يوفامين ماكو كلش ريسك عالي، بس better to be avoided in the first month of lactation baby with يعني first month of age. After 1 month we can use Uvamine safely.
وعفوا دكتورة هو for the same reason اللي هو relative immaturity of the enzymatic system of the RBCs.
هو challenging for يعني hemolysis. فلذلك يعني although it is secreted in the breast يعني in low dose, but it should be avoided. In the second month of age we can give it.
هو حقيقة أستاذة إذا تسمحي لي إحنا كشركة يعني we are خلينا نقول restricted بالضبط للليترشر يعني ethically we cannot promote it during lactation ما دام مكتوب عندنا بالليفلت أنه it is excreted in trace amount in breast milk، وطبعا أكيد هو الفاينل decision to the doctor مثل ما تفضلتي.
نعم. أنا بس عندي سؤال. عفوا دكتورة سحر، عندك تعليق بعد لو أسأل سؤالي؟ بس عندي تعليق على الكرانبري. دكتور علي علق على الكرانبري إنه ب 2019 نزل إنه does not يعني contradictory results of use of يعني cranberry in the prevention or treatment of يعني ال recurrent UTI حقيقة من 2017 بالاي EU assembly يعني بالEuropean Association of Urology بال 2017 قرروا انه you use او you don't use the cranberry it's the same. هاي قد يقول لك انا قناعات، يقول لك انا شو عندي دا يشتغل كذا كذا، بس شغله مهمه يعني اثيرها دائما الاحظها from my يعني gynecologist colleagues the use of cranberry FDA the use of cranberry in pregnancy تتوقع انها كاتيجوري الكرانبري يقول لك هاي سبلمنت يعني شكو بيه تتوقع انها كاتيجوري.
Yes, هي النيو ريسيرش أنا بصراحة I have been يعني read in a new يعني single study that not recommend a cranberry for long time during pregnancy.
لا مو does not recommend دكتورة ال FDA هذا احكيك هسه الآن دققت عن دققها سابقا ودققتها هسه بال FDA كاتيجوري X يعني avoid in pregnancy and lactation. So يعني please our يعني أنا بالنسبة لي ما استعمل كرانبري أبد يعني ما أبد ما استعمله بس please avoid in pregnancy avoid category X يقول تشيكوا إذا تحبون تشيكون بالميدسكيب تشوفون use of cranberry يقول لك كذا كذا طلع بالpregnancy يقول لك avoid in pregnancy. So please don't use cranberry in pregnancy.
cranberry as a fruit or as يعني
لا
high
مو فروت لا يعني لا هو اكل يعني هو كاي اكل ما له علاقه بس كاحكي كتريتمنت كيعتبر تريتمنت او سبلمنت او وات ايفر يعني. نعم انا خلصت اسئله وبعد ما عندي تعقيبات تحبون تضيفون شيء اساتذه؟
شكرا جزيلا دكتور.
شكرا جزيلا دكتور علاء، شكرا جزيلا اسينو،
شكرا جزيلا
كل
اساتذه.
الحاضرين.
شكرا جزيلا شكرا جزيلا تصبحون على خير.
مع السلامه.
مع
شكرا جزيلا تصبحون على خير.